Welcome to The Explainer. I'm so glad you're joining me today because we are tackling a topic that is, quite literally, a race against the clock. We're going to explore the raw mechanics of a stroke. It's an event where simply understanding the brain's delicate, intricate plumbing system can actually mean the difference between life and death. It's a fascinating and incredibly high-stakes look at human biology.
Okay, let's just dive right in. Picture this. You're going about your day, and suddenly, you are struck with what doctors call a focal neurological deficit. Basically, a sudden, total loss of function in one specific part of your body. What exactly is happening the very second that clock starts ticking? Well, the medical mystery we're unraveling today is all about those unseen, silent physiological disasters happening inside the skull, minute by agonizing minute.
To really wrap our heads around this mystery, we've got to start with the basics. At its core, a stroke is basically the ultimate plumbing failure. It is the interruption or a very severe reduction of blood supply to a specific area of the brain. Without that immediate, continuous flow of blood carrying crucial oxygen and vital nutrients, brain cells simply cannot function. And if that flow isn't restored incredibly quickly, those brain cells die. It really is that simple, and honestly, that terrifying.
So here's our roadmap for today's explainer. We'll kick things off with the anatomy of a stroke, compare blockages versus bleeds, hit the diagnostic crossroads in the ER, look at emergency acute treatments, and finally, wrap up with long-term management.
All right, let's jump into part one, anatomy of a stroke and the brain's plumbing.
A foundational rule you absolutely need to know right off the bat is this. A stroke in the brain always affects the opposite side of the body. So if a vessel fails on the left side of your brain, it's the right side of your body that suffers. And the brain's cross-wired mapping is incredibly precise. Just think about how specific this is. If a patient suddenly has issues with their speech or weakness in their face and arm, doctors almost immediately suspect a blockage in the middle cerebral artery. If the legs and feet are prominently affected, well, the anterior cerebral artery is your likely culprit. Now, what's really fascinating and frankly terrifyingly specific is the paramedian artery supplying the pons. A blockage there leads to what's called locked-in syndrome, where the patient's entire body is paralyzed. They're essentially locked inside themselves with only vertical eye movements remaining intact.
Moving right along to Section 2, blockages versus bleeds, two completely distinct disasters.
Now, this right here is the central conflict of our whole explainer. Why? Because every single stroke falls into one of two entirely different categories, and they require completely opposite treatments. First, you have an ischemic stroke, which means an artery is totally obstructed by a clot. It literally starves the brain of blood. Now, this clot can form locally due to chronic atherosclerosis, where fatty cholesterol plaques build up and finally rupture. Or the clot can be a traveler. It can travel to the brain from somewhere else, like the heart, which happens a lot in patients with atrial fibrillation. A hemorrhagic stroke, on the other hand, floods the brain. An artery actually leaks or violently ruptures due to high blood pressure, maybe an overuse of blood thinners, or an abnormal vessel like an aneurysm. And the crazy thing is, not only are the tissues beyond the bleed starved of blood, but the bleeding itself triggers severe vasospasms, narrowing the surrounding vessels even further.
Which brings us to Section 3, the diagnostic crossroads. And trust me, it is a high-stakes decision.
Just imagine a patient being rushed through those ER doors. They're presenting with these massive, immediate warning signs. Sudden unilateral paralysis of the face or arm, slurred speech, sudden loss of vision, or maybe a severe thunderclap headache accompanied by vomiting. The absolute very first thing a doctor must do when they see these focal neurological deficits is order a non-contrast CT scan. You might be wondering, why non-contrast? Well, because it's the absolute fastest way to get an image. And in this moment, speed is literally everything for the life or death choice they're about to make.
And that brings us to the golden CT rule. When that scan pops up on the screen, doctors are looking for exactly one thing. If they see white, there's blood present. It's a hemorrhagic stroke. If there's no blood, the area will eventually show up as a black patch of ischemia or cell death. Getting this read wrong is fatal. Think about it. If a doctor assumes it's an ischemic block and gives the patient blood thinners to break a clot, but it's actually a hemorrhagic bleed, those blood thinners will critically aggravate the bleeding and kill the patient. So this simple black and white image is the ultimate medical crossroads.
All right, Section 4, emergency acute treatments, beating the clock.
So for the rest of this explainer, we're going to assume that CT scan showed black. There's zero blood. That means we're fighting an ischemic stroke, and we are officially on the clock. The ER protocol here is a very strict logical progression. Step 1, as we just covered, is confirming there is absolutely no blood on that scan. Step 2 is the big one. Deciding whether or not to administer TPA, or tissue plasminogen activator. This is a super powerful clot-busting drug given intravenously to literally dissolve the blockage. But it carries a massive risk. Busting a clot and forcefully rushing blood back into damaged, fragile tissue can actually convert an ischemic stroke into a bleeding hemorrhagic one. And finally, step 3 is the incredibly delicate balancing act of managing the patient's blood pressure.
4.5 hours. That is the magic number here. TPA is an incredibly powerful tool, but it's typically only given if a patient presents within 4.5 hours of their symptoms starting, and if the patient happens to be diabetic, that window shrinks down to just 3 hours. If they arrive after this strict window closes, or if they have contraindications like, say, a recent surgery or a history of bleeding, TPA is completely off the table. Instead, the patient is given 325 milligrams of aspirin. You see, TPA undoes every single clot in the entire body, so giving it outside that safe window risks catastrophic rebleeding.
Now let's talk about this wildly fascinating concept called permissive hypertension. I know, it sounds completely backward, right? We're always told high blood pressure is bad, but during an acute ischemic stroke, doctors actually want the patient's blood pressure to stay abnormally high. Unless the patient was just given TPA, physicians will allow the blood pressure to stay elevated, keeping it just below 220/110. Why in the world would they do that? Because that intense high pressure is actually the body's natural adaptation mechanism. It's desperately trying to force whatever little bit of blood it can past the blockage to keep that dying brain tissue alive. If you were to aggressively lower their blood pressure right then and there, you'd cut off that lifeline and cause even more ischemic damage. It is a truly brilliant paradox in emergency medicine.
Finally, we hit section 5, long-term management and unclogging those pipes. Okay, so the patient has survived the ER. Amazing. But now, doctors have to totally switch gears. They go from being first responders to full-on detectives, trying to find the root cause and stop a second stroke from happening. Chronic care targets every specific system. They'll run an ECG, and if it reveals an erratic heartbeat like atrial fibrillation, the patient gets immediately prescribed anticoagulants like warfarin to stop traveling clots in their tracks. They'll do an echocardiogram to look for physical clots that might already be hiding in the heart's chambers. They draw blood to check the HbA1c to manage any underlying diabetes and look at lipid profiles to get them on high-potency statins, like atorvastatin, to aggressively halt that atherosclerotic process. They'll also prescribe a low-dose daily aspirin, usually 81 milligrams. And of course, there are mandatory lifestyle changes, like quitting smoking immediately, paired with intensive speech and physical rehabilitation to help rewire the damaged brain. But there's one specific test on this list that can actually lead to a surgical intervention, and that's the carotid ultrasound.
70%. When doctors are looking at the carotid arteries in the neck, those main supply pipes right to the brain, they're hunting for atherosclerotic plaques. If that ultrasound shows less than 70% stenosis or narrowing and the patient doesn't have any symptoms, they'll usually just treat it medically with statins. But if that narrowing is greater than 70% and it's causing symptoms, or it's over 80% even without symptoms, medication just isn't going to cut it anymore. The patient needs surgery. A surgeon will perform what's called a carotid endarterectomy, literally opening up the vessel to physically scoop the plaque out, or they'll do carotid stenting, where they pass a wire in and inflate a tiny balloon to permanently widen that blocked pipe.
So, we've seen how a stroke is essentially a catastrophic plumbing failure. We've mapped out the incredibly complex brain wiring it destroys, and we've walked that razor's edge of emergency ER decisions. The brain's network is unbelievably fragile, and the speed required to save it is absolute. Understanding the warning signs and the intense science behind the treatments isn't just fascinating, it's deeply empowering. So, what happens when that clock starts ticking? Will you be ready? Thank you so much for joining me for this explainer. Keep learning, stay curious, and I'll catch you on the next one.